Welcome everybody to the Spring 2022 lecture series of the School of Architecture and Design at New York Institute of Technology. I'm Alessandro Mellis, the chair of the Lectures and Events Committee, and would like to welcome everybody on behalf of our Dean, Maria Perbellini. The topic of our lecture series this year is communities, and we intend this as a community beyond borders. We think this last aspect, by the way, is especially important these days. This will offer opportunities to discuss and debate how the application of architecture, design, digital arts, and urbanism in this context can achieve a positive impact, innovate, and be of benefit to communities and society. Today, I particularly thank Christian Pongratz and our distinguished guests, Paul Barak and Sean Hagen, for having conceived and curated this event within the context of the Master of Architecture, Health and Design. The moderator of this event today will be Christian Pongratz. Is the senior advisor to the provost and professor of architecture. Is the director of the program, of the master program, Architecture, Health and Design. From 2017 to 2019, he was the interim dean of the School of Interdisciplinary Studies and Education. Prior to joining New York Tech, Christian was the director and founder of the Digital Design and Fabrication Program and Master of Science specialization in the College of Architecture at Texas Tech University, where he was also a professor. He taught at the School of Architecture, University of Texas, Austin from 2000 to 2002, and was visiting professor at Yeonjin Junior College, Daegu, Korea, the Busan International Architecture Design Seminar, Busan, Korea, and at the Architectural Association. He's a jury member for the Pinnacle Awards by the MIA since 2007. He studied architecture at the EU Munich and SCI-Arc, and is licensed architect in Germany with registration in Berlin. Before establishing his own practice, he worked in New York for Peter Eisman and John Reibnitz, and was involved with the design of international invited design competition with prestigious commission building. So as I mentioned, Christian is also the director of this master program within which we are today organizing this event. So I would like to leave the stage to Christian so that he can introduce the topic and introduce our distinguished guests. Thank you, Christian.
Thank you, Alessandro, and welcome everyone today to our kickoff event here on health and design. And I think different than we had often the impression over the last 2 years or so, health, we believe, and we think very strongly, is essential to a population's economic, cultural, and social future. And we want to use this discussion today in an interactive way, hopefully, and shed some light on the interplay of design with health, and think that this first event here puts an initial focus, of course, on issues around healthcare. Now, as we reflect on health outcomes, we want to, with that, start a series actually of transdisciplinary roundtables, and think that those could be an opportunity where we frame health in a much broader sense, and we try to understand the importance of well-being and how we can provide better health to everyone. So we hope we have discussions from here onwards and use the umbrella of our new Master of Science in Architecture, specialization in health and design, which I think is a unique program in that it differs from other programs that focus more narrowly on healthcare facility design, in that we think we want to situate ourselves precisely at a new intersection where research fields at, let's say, different disciplines impact exactly an individual's health. Now, the participants here in our first discussion today, Dr. Paul Barak and Sean Hagen, represent exactly this intersection that I mentioned. They're renowned experts in strengthening healthcare systems and designing safety patient outcomes. And they are leaders in our new MS Health and Design course on innovation in healthcare systems. This course puts particular focus on the clinical care environments where the prior neglected risks to patients and staff in healthcare settings should now create an awareness for new roles, as we believe, and competencies in this really emerging and growing health design field. Now, Dr. Paul Berek is wearing many hats. He's a leader in designing safe in-the-citizen systems, faculty and professor at many US and international universities, and is also an active and renowned board member in global health organizations. And now, as part of our team here in the Health and Design program, he brings his expert knowledge of innovative healthcare redesign and how to improve the delivery of health outcomes to our New York communities and to our students. John Hagen, instead, a designer in his formation, is the founding principal and director of research and synthesis at Black Hagen Design, and a subject matter expert in human factors and usability design. Leading that team in his office and his firm, he spearheads deep user research, driving innovation in product design in the medical field. He's also a contributing author in most of the pertinent usability standards for medical design and for development. And with that, I would like to give the word now, of course, more to our experts here today, and ask you, Sean, maybe to start off and give us a bit more deeper insight into your industry and your actual work.
Sure, thank you for the introduction. So from my perspective, it's mostly from the product development side. So the devices, environments, and systems that are used in healthcare. And our firm over the last 26 years has become specialized in usability design. And so that takes into account a whole lot of different factors, and the span and breadth of this course that we're offering will cover up all those factors. It's a challenging balance or harmonization between ease of use and use safety. There's a lot more to it that sounds very simple, but it's not. And so the experience that I bring to the table is having worked in the medical industry from the perspective of developing devices and systems that remain safe and promote safety throughout the healthcare ecosystem. I have a lot of examples of how methodology and systems thinking can drive that end goal of safety and efficacy. So that's going to be the perspective that I bring to the table. It's from a product development side. I've observed surgeries in 20 different countries. So most of our clients are all international. So the development of devices, you need to understand exactly how they're being used, by whom and why, and what their aspirations are, what their user experience expectations are. So I think this will be a good reflection on how to apply design thinking to the broader scope of healthcare. And Kristen, did you want me to show my visuals?
You talked about patient experiences also, and I think, yeah, if that maybe is helpful for that, we could do that right now, or we can lead over and have.
Sure, it's actually more of an overview of the entire course, but I will address that. Healthcare is not just hospitals or clinics. Obviously, it's migrated to the home more so now than ever, and that's always been part of the scope of what we've done. So when I say I observe surgeries in 20 different countries, I've also observed people being patients or caregivers using products in their home in many different countries as well, probably about 18. And so there is context of use, which we address in our course. That it's a trend that actually is becoming more prevalent every day, as hospitals realize it's smarter to get people out of the hospital as soon as you can and ambulating back at home. Healing just takes place faster that way. So there are economic impacts of that, obviously, as well. But more importantly, from the perspective here is how do you make sure that remains safe when now you don't have a professionally trained caregiver or a healthcare provider utilizing these devices, systems, and expectations.
It's maybe a good moment then maybe to lead over to Dr. Paul Barrack, whose experience, of course, is very strongly about patient safety. And maybe you can explain more, Paul, on how you see kind of those situations moving from clinical environments to home environments and vice versa, and give some background on how that translates maybe possibly also into teaching.
Delighted to. Hello, everybody. Good morning. Let me just make sure that you can see my slides, first of all. Can you see them?
Yes. Thank you.
All right. So I'm delighted to be with you here today to introduce our course. Sean and I have been working on this for a while. We bring to it probably a combined 70 years of experience around healthcare, starting with the design of devices, understanding the problems that Sean alluded to, onto the clinical aspects, which is the patient experiences, the clinician experiences, and ultimately, how well does the system behave? My experience as an anesthesiologist and as a intensive care physician over about 25 years has been trying to better understand how do we design better systems in order to design better outcomes. And I want to show you some examples of that. Again, can you see my slides?
Yes, yeah, sure.
So here's one of many examples. Here's a small child who died from an air embolism because of a poorly designed IV bag. In this case, the bag is a liter. Obviously, for a child that in this case weighed about 10 or 11 kilos, they were supposed to get about 100 cc's of fluid. But because they used a 1 liter bag and there wasn't a one-way valve, after the fluid went in 10 times the amount, then all the air went in and caused an air embolism. And so the solution here is rather simple. It's a very simple industrial design solution. And yet still in most hospitals, most IVs do not have this type of design, a fail-safe design, if you will, to make sure that the air in the bag, once the fluid is out, does not rush into the child. In adults, the amount of air is small, but in children, the relative amount of air can actually lead to an air embolism and death. Here's another of my favorite examples. This is somebody who had a guide wire put in, and a guide wire is used to guide a catheter into somebody's body. And as you can see on the picture on the left and the right, what you're seeing is the catheter it's not just the catheter, but the guide wire that was supposed to be pulled out, Sean, was left inside. Because you have to actually manipulate the plastic catheter over the guide wire. And so it seems pretty straightforward, but imagine for a moment that somebody's fixing your electrical system and a screwdriver falls inside the system and they just close the wall. That's sort of what can happen because of a poorly designed guide wire that is left behind. And here is an example of a paper from some colleagues of mine showing how many guide wires were left in one hospital. So you can see over a period of a few years, multiple guide wires were left behind in people, which required surgical intervention. Here are other examples. These are drug labels, bottle size, bottle color. All these drugs are very different, and yet they look alike and sound alike in shape and color. This is all about the design of the labels, the size, all these things that we rely on in order to better get input from the environment. All these cases came to me because of serious adverse events, either serious morbidity or death, because of a misunderstanding by the clinicians who gave the wrong drug. Imagine for a moment in your bathroom, you have vitamins and rat poison, and they're in the same type of container. How often would you knock off your spouse that way? So this is a pure design problem. But of course, it's put on the shoulders of the clinicians. So, well, why don't you read the label more carefully? Design at the end of the day is at the heart of what we're talking about. So these are other examples I've brought to me. Each of these cases, the patient either died or was seriously harmed because of poor labeling, poor naming, poor structure of the bottle size, the bottle shape, the bottle color, very, very design sensitive aspects, which we hope to talk about in the course. You've all seen these wonderful improvisations of people who find ways to do some really silly things, right? Well, guess what? We do that in healthcare as well. Here are pumps that are designed to run for certain drugs or And then what happens is that even though the pump is designed to run on drug A, people take tape, as you can see here, and they cover up the original design, and then they put a different drug inside, which leads to problems of flow. So this is flow shown through medication pumps, a whole interesting field that we'll talk about. It really is a wonderful intersection between technology, cognitive understanding, medication safety, and healthcare flow.
And
so this
infusion pumps are migrating into the home as we speak. So
yeah,
you can see how dangerous that could be.
Yeah, so this is my operating room. Does anything strike you as unusual? So if it appears chaotic and stressful, it is. This is the best that human engineering can design in the year 2022, which is really an interesting challenge in itself. You have 9 people in this room, which is the size of about 400 square feet. Again, complicated, noisy, distracting, a lot of questions of performance and things like that. So this issue that we're talking about is all over the country. Here are examples of 4 major newspaper stories in the last few years on major adverse events that led to massive branding problems. Johns Hopkins lost $200 million on the event below when it had to shut down its children's cardiac surgery program in St. Petersburg a few years ago. Many, many other examples where executives lost their jobs, hospitals were punished because of poor design problems supported by poor cultural problems, leading to poor outcomes to patients and to staff and to organizations. So this is what the data looks like. The more we look, the more adverse events we find. So our course, we hope, will help you think about why these problems continue to plague the US and international healthcare systems. When you look at the Joint Commission, which is the main regulator for the US, you can see the #1 problem, Sean, human factors. So that's what this course is about: human factors, leadership, and communication, these core elements that are about 90% of the reasons why patients are harmed in clinics and hospitals, or now more and more in ambulatory home-based settings. Again, not a unique problem to the US, it's an international problem in Europe and Australia. These are different examples from the OECD, from the Lancet Commission, from the National Academy of Science, highlighting why designers, architects, engineers, and industrial designers are at the heart of helping to rethink how healthcare can deliver better safety, better quality, and better financial value. They're tightly connected, these things. I'll be remiss if I didn't talk about this problem, which is massive, and COVID has made it worse. Massive resignations of nurses and doctors in the last year, rates of 40 to 50% of burnout. And I believe one of the key reasons is because of bad design. When systems are badly designed, they lead to massive frustration by nurses and pharmacists and physicians and contribute to the medical errors, which then leads to punishment and punitive issues and ultimately leads to embarrassment and shame and serious financial implications. So the heart of the course is really this idea that how do we deliver care and where we have patients that are more satisfied because they got good care, because their pain was alleviated. The providers are not frustrated because they have the right technologies at the right time. The cost of care is such that it can be borne by the patients in the system, and ultimately it improves the population health. And so in the course, we'll talk about how do we measure these things, what are the fundamental research methods to actually do implementation research. So how do we actually design a system that will actually work in New York or Chicago or in Rome? So I want to now show you a very brief video. This is from a book that we wrote about 6 years ago. It's 24 case studies and some videos that accompany them. So I'm going to show you just a few minutes of one of the videos. And in the course, we're going to have some examples in which we have patients telling their story. And then through the story, we're going to invite the participants using these types of tools to think about the process, about the flow, about the human factors, all the things that come to bear in this case, and how a healthy 15-year-old died at a major marquee hospital because of poor design, poor technology, poor system resilience, and ultimately lack of respect for the patient, in this case, the child and their mother, and led to a terrible outcome. So Anna, if you could please start the video.
Okay.
Stop sharing.
Okay, hold on.
And then I'll tell you when to stop it because we're just going to show part of it.
Can you see it?
Yes.
Okay. Can you see it?
Was a very bright kid. He was one of the top students in our state. But he had
Can you increase the volume, Anya?
the first condition called sex development. And when he was 14, I saw an article in the newspaper saying that there was a new procedure that was much safer than the old surgery to correct this condition. We'd never really thought about it until we saw it. So we went ahead and signed up for the surgery. When he came out, he seemed fine. His chest looked great. But he wasn't urinating. For some reason, he'd come in dehydrated and not given him medical fluids. But in the meantime, he had a very heavy-duty hemorrhage surgery. So he was on an epidural with a lot of narcotics, hydromorphone, and he also was taking every 6 hours an injection of IV Toradol, which is an NSAID. It was very hard to control his pain until they kept wrapping up the narcotics in the epidural. But nobody ever said anything about Toradol. It was bright red, very itchy, and nauseated. And what had happened was they had just given him the loading dose of the 6 Toradol. And he stayed that way the entire time in the hospital, itchy and nauseated. And they never stopped giving him Toradol. You know, we sort of rocked along for several days. There wasn't too much change in his condition. He didn't get better, he didn't get worse. It was a Sunday morning. They gave him this Toradol injection at 6 in the morning. And half an hour later, he was suddenly in agonizing pain. And it was not at the incision site, not at the surgical site, but in his here, in his epigastric area around the stomach. So we called the nurse, who was really quite alarmed, and went running out of the room, and then came running back in, bustling back in a few minutes later, saying, "No, it's just an ileus, it's just constipation." All through that day, it got worse and worse and worse. I kept asking for the doctor. I finally went and found the nurse in the break room, and I said, "I want to see the doctor." And she said, "You've just seen the doctor." And I said, "No, that was the intern. I want a real doctor." And after more hours, the young man shows up. He also pronounced that it was just an ileus. It seemed to me that it would cause a kind of pain. And I said, "But what about the cold sweat, circles under the eyes?" And he said, "Oh, that's just from the narcotics, because he's opiate naive." He wrote in the chart heart rate in the 80s, when Lewis's heart rate had been over 120 for quite some time. He was, in fact, not an attendant as we waited, a resident. So Lewis, through the night, got much worse. The first and second year residents and the medical students. And they concluded that Lewis was better, because suddenly Lewis's pain disappeared, which is not a good sign. 8 in the morning, when they came to take his vital signs, he had no blood pressure. They took his blood pressure 12 times with 8 different machines and blood pressure tests. They had never done a hematocrit. They'd never tested for infection.
Anya, maybe you want to stop that?
And as they were doing that,
Can you hear it?
Yep, but if you can just turn it off now, just give me back the permission.
Okay, did you see it and hear it?
Yes, it was
Okay.
just low the volume, but yes, we'll talk about that afterwards if we can amplify the signal.
Okay, so you want me to do anything?
To stop the video and just allow me to share my slides again.
Okay, sure.
So this is a very unfortunate case, and the child died, and a whole range of issues around poorly designed technology. They didn't quite understand the flaws of why they couldn't get blood pressure, so they kept on bringing in more devices, even though the problem was there was no blood pressure. The communication, the coordination. Here are one of the tools that we'll share during the course, tools that are used to analyze a complex patient, better understand how these things happen. And now as we move forward, how do we learn from these other industries around cases like this? You know, these industries are able to operate at 1 in 24 million process failures, or sometimes 1 in 750 million, whereas in healthcare, it's sometimes 1 in 10. 1 in 20. And so the staggering rates of lack of safety as opposed to these other industries is something that we'll talk about in the class. We'll talk about these fundamental texts like Donald Norman's book. How do we design systems for success? And what is the responsibility and the ownership of the designer in minimizing the errors and setting it up for success? We'll speak about flow. This is Deming's work, how systems are designed for success. Again, these are the foundational texts that we'll allude to during the course. We'll talk about work as imagined by the bosses, by the media, by the designers versus the actual systems. So work as imagined versus work as designed. And then we'll think about how, from left to right, how these latent failures lead to problems that then manifest as harm later on. And again, the answer, of course, is ultimately it's about the design, it's about the opportunities to address these issues upstream and to measure them. So we'll also talk about, this is a process control chart. It allows us to then measure variation over time and allow us to understand, is the variation truly statistically important, or is it just noise in the system? Again, finally, we'll talk about the culture. This is a great example of the NASA space shuttle that blew up. And as you probably know, at the end of the day, it wasn't about the technology or the O-rings, it was the culture. So what is the culture that engineers and architects and industrial designers help create, and then led by managers and executives, that allows a system to perpetuate and normalize deviance? So we'll talk about that connection between design, technology, regulation, and ultimately the culture that supports it. How do we capture these events? Again, these are just a snapshot of what we'll talk about. How do we help think about the culture between a pathological culture versus a safety culture? We'll learn from Formula One, because we've learned a lot how well they do, because other industries have really perfected applied human factors. How do we communicate more effectively in different ways? We'll show how videos from our operating rooms, as well as in the simulator, how we can reintroduce and understand the concepts of using cameras, audio, video to better understand in design, as well as debriefing and feedback. And then we'll talk about some of the training programs that we've developed to help improve the relationships between the technology, the clinicians, and the oversight of the system. Again, stuff that's being used, this program that we developed 15 years ago is now being used in about 800 US hospitals. Finally, we'll talk about high reliability systems. This is really the cutting edge of modern industrial organizational improvement these days. How do we design healthcare from the beginning with the idea that we focus on failure modes, we focus on better design that allows us never to forget the complexity at the sharp end, and how do we build resilience from the architecture, the engineering, the industrial design, through to the recruitment, the support, and the management. So finally, this sort of model that is the SEPS model that comes out of Wisconsin, this idea that the work system on the left can be designed, the cultural processes, and the ultimate outcomes. So this really kind of brings it all together, the process design, the culture design, and the human factors. That will be our goals in the course. So I will end with this lovely Harvard Business Review cover that argues that the main challenge is not AI, It's not the technology, it's the culture. And so, and the culture is manifested through better design, through better incentives, and through better alignment. And that really is what Sean and I hope to achieve in the course. So I'll end with that. Thank you.
Thank you, Paul, for this great overview here on the various aspects that you want to discuss in the course. And I think certainly very, very clearly for us was here the understanding that there is a lot of failures that is happening in our environments. And I would also think that many of us, particularly going through COVID over the last 2 years and ongoing, we're very much aware about failures even in our personal and home environments. You spoke a lot about, of course, those shortcomings in care environments. But certainly I understand that there is many aspects where designers that on a daily basis not just shape buildings, they shape an urban scale, they shape interiors, they shape product design, and that's in all our environments. And reflecting maybe in particular to COVID, right? So we have this aspect where our immediate environments, even in our families, were questions of let's say failures and safety. And so for example, the particularity maybe of door handles, right? Like in this case, so the company Materialize was one of them that they kind of sponsored this kind of competition here on how to rethink door handles. But I remember that many architecture schools actually tried to design masks, try to design other ad hoc tools and devices in this kind of emergency coming up with COVID, right? Now, of course, we all think about immediately surfaces. How and where are we surrounded basically by surfaces that actually are the ones where the microbes somehow mingle and sit. And if you talk about that, then we will also say, but actually there is a lot of, let's say, microbes that are actually beneficial for us, right? So our food is full of that, and our gut nutrients kind of control our well-being, but on the other hand also can lead to infectious viruses, etc. So we see that kind of idea of surfaces across environments is something very predominant and appears to me one element, of course, of intervention. And I think that also Sean is here particularly working in some of those areas because of his expertise on what he calls contextual inquiry, on analysis of various artifacts, environments, and also looking into areas of service design, let's call it, analyzing flows of people, in spaces, usage of tools, etc. And I think there's certainly a good feedback also from his experience. No.
Sure, I can expand on that. So that Paul had mentioned a couple of disciplines that I want to preface some visuals that I'm going to bring up next to describe the structure of our course. He mentioned industrial designers. Industrial designers bring to the table lateral thinking and creativity. Human factors engineers, they bring in the rigor of science and what are the limitations and capabilities of the physical human body as well as the cognitive. And then ultimately systems engineering, which is going to provide us a non-confined, more broader and overarching perspective on how to solve problems. And these are all things that we both believe, we all believe that are going to be critical in improving our healthcare ecosystem in the future. So I'm going to share my screen here. We have developed a course that's broken up into 5 what we call modules. Is everyone seeing my screen?
Yep.
Great. So this is in general, we're just, our overall title here is just to talk about how design thinking can improve and innovate within the healthcare ecosystem. And what we're going to do is break it, as I mentioned, break it up into these 5 modules. So developing a safer and more reliable care delivery system and the tools to enable that system, how to discover opportunities, insights, and innovation within the healthcare system, designing easy to use but also safe to use care solutions. These are often conflicting criteria, so that's a trick. And then some of the tools that you're going to need to understand in order to solve problems in the future with regards to analysis, measurement, and ultimately the design of better healthcare outcomes. And then lastly, as Paul has really stressed on, is what can we do to foster a better culture that addresses patient safety, which is frankly the second pandemic. I mean, the number of people that die in the US alone every year is in the hundreds of thousands, of all preventable incidences, and were either based on the system, the design, or the culture. So these are the modules that we're going to divide everything up. Those adverse events that he talked about, they're not all related to just product design nor environment, but there's always a human involved. So you need to understand that context, and we're going to cover that. So we're going to start with a module that's about developing safer and more reliable tools and systems, and that's going to be founded on risk analysis and risk management, and then how that equates to better product development when you address and mitigate usability risks as well as systems risks. So this example here is just a home product for taking a blood sample. And then, as Christian had mentioned, we also want to talk about methods and means to collect data from the context of use. You can ask somebody how they use something. Ask a surgeon how she uses an instrument in your office, and she demonstrates it one way. I ask her after watching several surgeries and noticing that she holds it exactly how she described, but she also holds it another way. And then I can ask her afterwards and say, was there something different about this procedure because you held it different? And the surgeon replies, no, I didn't. And there's a lot of biases involved. Most of them have to do with memory. And so they're not even aware of the behaviors. So this contextual inquiry, or ethnography as it's sometimes called, is a super powerful tool that we're going to give you a lot of insights on how to implement and apply to all aspects of the healthcare ecosystem. And that includes hands-on application of those learnings, where we'll actually have you in a simulation center observing a high fidelity simulation of a surgery and apply those methodologies and techniques. And then there's this challenge, this conflicting set of criteria between ease of use and use safety. That this has always been a challenge within both product design, systems design, architecture, et cetera, within the healthcare system. The whole delivery system, they even applies to the culture aspects of the healthcare ecosystem. So we're going to address that. It's obviously extremely complex, as these pictures sort of, one on the right, this is a person has blood. This is before we had the COVID-19, we had bird flu. This was a patient on bird flu. And then this is just on the left is a cardiac procedure and some concerning behavior at the point of care. And then how this ultimately translates into both systems, environments, culture, and products. In this case, because I run a product design firm, I'll be able to demonstrate. It's a little more simplistic at the product point of view. Then we're going to also help you understand techniques, methodologies, and systems with regards to analysis and how to collect those data and then how to implement the data, and what that might look like applied to all aspects of healthcare. And this is on a foundation premise that there's a lot of things that we don't know. And so how do you come to those conclusions, whether it's knowledge-based assumptions just general ignorance or just risk-based. And there's going to be methodologies and techniques that will demonstrate that address these four quadrants. And then lastly, this is the part that really hits home, especially some of those case studies that Paul just gave us. How do we foster and steer a culture of patient safety? Culture is probably the most difficult thing to design because it takes a lot longer. And there's so many complex inputs to it, from paralegal to ethnicity to corporate to systems design, et cetera, et cetera. So these are all things that we're going to give you case studies and examples of how it can be applied at a very broad stroke down to a very focused set of examples. And when I talk about the broad strokes, it really zooms out greatly to an ecosystem of stakeholders that ultimately are going to have to be influenced and some behavior changed in order to come up with a more safe system, because these avoidable adverse events are happening every day. It's the equivalent of a jet airliner falling out of the sky every day. So we have to do something about that, and it's going to take some great deal of creativity addressing this whole ecosystem, be it at a foundational educational point of view, down to how adverse events are managed within hospitals, how they're the Joint Commission oversees that, because there is no federal, unlike an airliner, there is no federal oversight body. The funders, the corporations, et cetera, et cetera. So it's a very complex problem. And we're hoping that the learners and students that enroll in this program are going to be instrumental in steering this in the right direction, because it definitely needs that kind of attention. So that's where I'm at, Christian. I'm going to stop sharing.
I think that was pretty impressive, I believe, for also our audience here. When we see those images and we see the actual complexity that is involved in, particularly maybe here most in care environments, yeah, the amounts of devices we see, the amounts of material, yeah, and I think, I'm not sure exactly the number, but we spend about maybe $170 billion on medical devices, yeah, on a regular basis. And we have maybe medical expenses in the trillions, right? What we see here is also, and make no mistake, we really want to be clear about that. This is not a field that should stay maybe very much enclosed just for care clinicians, but we are actually talking about in opening up that field, right? Bringing in actually other experts, and in particularly here designers, yeah, that can help assist in those various processes, right? Untangle maybe some of those complexities, and hopefully play into what you mentioned, the kind of balance between ease of use and safe use in environments of devices and tools, etc. Yeah.
And it's going to be imperative that the business people, the CEOs and COOs are up to speed on what this impact means, and have some insight as to how to address it in a more holistic manner.
I'm sure we have also, I see Paul wanted to follow up on that. If anybody of our audience has questions, etc., I would like certainly at one moment maybe to have one or two members either chat or post some questions. Yeah, Paul, do you want to?
Well, I just wanted to respond to Alessandro's wonderful question about technology and creativity. And Alessandro, when I worked in the Netherlands many years ago for a year, I was struck by the fact that because, as you know, the Dutch love football, soccer, they decided to remove the access to the operating room doors and the handles. Instead, they had a silver plate about 4 inches by 4 inches where you'd kick it, and that's how the door would open and close. And by doing that, they reduced the chances of infecting the handles and contaminating each other. And so the design was very culture specific because the Dutch love that. They wear these very unique clogs so they didn't hurt their toes. And it was a gorgeous solution for a Dutch environment, aligning creativity and technology. So I think we can do that, but it's a wonderful question why so much healthcare technology lacks creativity. So that's a challenge, I think, throwing out to designers on the call.
Yes, I really thank you, Paul. By the way, always use the word football, not soccer in Netherlands. No, besides joking, I perfectly, yes. I mean, this is a key question, especially today where we see that, let's say, technocratic approach to the problem is not solving the problem. I mean, this is what we see. So the creativity is probably also the wild card that in times of climate crisis can help us to go beyond the, let's say, work out of the box, let's say. So I'm telling this because sometimes we have this idea that technology is the useful thing and creativity is some kind of chit-chatting thing. But we always have to remember that technology, I always quote this famous paleanthropologist who said that technically from a brain perspective and a paleanthropological perspective, there is no difference at all between technology and creativity. So they belong to the same associative thinking that was born in a certain period and allowed us to overcome crises. So we simply have sometimes not only to think in more creative terms, but also thinking that probably there is not a real distinction. This is just an impression. So we need to be creative to make good technologies and vice versa. We need to understand technology to be creative. This is my impression.
And I don't know if, a common cultural, I don't know how many of you have watched Star Trek Picard, but in the 24th century, the solutions are cultural and humanistic, not technological. And again, that's entertainment, but it's interesting that this forward-thinking series has finally realized that there are great limits to technology. And the positive side, how do we deploy that to make our technology more empathetic, more humanistic, and more aligned with a social technical way of thinking? So that means this course, Alessandra and Christian, must have a lot of social science input, not just engineering, not just design, but anthropology, sociology, psychology, which is hugely important in shaping the design constraints and enablers.
Yeah, exactly. So it becomes a really, we call it maybe a transdisciplinary approach, where we try to integrate those various views of different disciplines. And I think that's maybe particularly important as we all witness a shift, maybe even in the way you talked about culture before, Paul. The model that we're all working within is actually kind of an old model, right? So this kind of relationship between patient and provider, this kind of single touch points over your lifetime. And it seems and appears that there is even new business models emerging right now, right? So I mean, how patients will have more say in the future, be more involved actually in the actual processes, and that we move much more from maybe a single provider-driven, centralized healthcare model to a much more user-centered and a much more preventative wellness and lifestyle health management. And I think that's where, in particular, I feel the knowledge comes in that you both bring to the table, right? This understanding of patient needs, of user needs, and of people needs in general, and how can those become more drivers in general in that model?
Yeah, in my industry, that being product development for healthcare, probably only 10 years ago, all these giant corporations just assumed they knew what was best and that their technology would fix it. And after falling on their face so many times and causing so many adverse events, they realized that it's in their best interest to really become intimate with the needs of primary, secondary, and tertiary users in context of the use of that device. And that's made all the difference in the world. And I think it's improved. I know that there's huge numbers on how many adverse events led to death in our country. But only about 15% of those had to do with use error regarding a device or a system. So this is the rest of that is about culture and communication. And that's where that's gonna be a much more challenging problem to solve. It's a lot more straightforward developing safe and efficacious devices than it is steering new culture and behavior.
We do have one question maybe in our remaining time that I see here that we could maybe reflect upon, and it's talking about the understanding of the relevance of this multi-scale approach, because there are complex issues, and we talked about this multidisciplinarity. So the question is, how does the presented work involve also public offices and administrations who are able to change policy and laws?
You know, the biggest challenge I find in this regard, Christian, is many universities and many course directors see this, perhaps because of their natural bias, as a monodiscipline problem. The complexity that Sean spoke to and the stories that we alluded to require universities to take a very different approach. That means basing it on real live cases, so very immersed learning. It requires using the best of hybrid and simulation abilities to bring the student into the immersive setting. And it requires a multidisciplinary approach like the Bauhaus movement 80 years ago, which argued that you couldn't be an architect unless you were an expert in photography, lighting, design, everything. It took 10 to 15 years to become an architect in the Bauhaus movement. That's an exemplar of a thinking that realized that the complexity in redesigning healthcare systems needs to be reflected in the way we train people. That means the course curricula, the carryover from year to year, the project growth and development. That's a different way of thinking about healthcare design. And sadly, very few organizations around the country or the world have been bold enough to apply this model, which Sean and I are promoting, and why we're so excited to help New York Institute of Technology lead on this, because it is totally different than anything else we've seen, because it's based on real world experience, and it's never far away from the world challenges that these graduates are going to face every day when they get out of the university, when they finish up.
Yeah, thank you for the comment here, Paul, and I want to maybe conclude here and say that it's really your expertise and this long experience that you have collected, and which we witnessed also in this conversation today about failed practices, failed environments, safety issues, and we all were so much aware about, particularly in our health environment in the last 2 years. And it tells us a story here that there's new roles that are needed in how we look into the broader health challenges, and in particular also from a design point of view. And it is both of you that you translate your vast experience into having dealt with those issues into what we see as innovative models and topics, and they will shape those course learning outcomes.
Yeah,
so we are looking forward.
For example, Christian, you know, if you look at World War II in the US, it led to the post-war largest boom in hospital design and architecture that lasted for at least 30 to 40 years. So if we think about the COVID pandemic, as tragic as it has been, as an opportunity to rethink how we train, how we mentor, how we coach, and how we bring teams together to think differently about these issues, then not only would the graduates be better off, but the way people talk about the course will be very different. It requires a different lingo, different terminology, ways of imagination to think about why past design impacts in healthcare have been limited or have not necessarily achieved the broader vision that should have been, if you will, or could have been. And so that's what's so exciting about this opportunity. Okay,
so Paul, I think this was maybe the nice concluding statement here.
Yeah,
so,
I just want to add, there is another
Yeah,
question that
Alessandro.
I'm raising, even if we are beyond, but because it's interesting, because it regards more specifically the course. So Dana Hamdan is asking if the course will also cover health care facilities in temporary ones, let's say in the, yes, in this period of transitory situations. So just a quick question, because I thought it was interesting to know about this for the program itself.
Yeah,
Thank
I
you,
think
Dana,
that was very, yeah, for me, when I saw the title, thank you first for the very interesting talk, like so many areas that I was not aware of. And for me, when I saw the talk, my first instinct was like healthcare facility in temporary settlements, as well as because we have COVID healthcare facilities that are temporary now, but we also have the longer ongoing issue of refugee settlements or informal settlements that have this design issue. And I was wondering to what extent you're covering that or addressing that area. And if you are going to discuss international cases, or is it US context centered?
They're definitely going to be international context. Specific to temporary hospital environment design, we probably won't go into that kind of specific, but we are going to cover in depth the methodologies and techniques you're going to need to design any kind of environment. And I'll give you, we have one case, well, I have one case study. There's a hospital being built at Ohio State where they're building in a department just for human factors and systems engineering. It's going to be a permanent part of the facility. And it's your approach, your planning, and your sensitivity to the context that will enable you to design a better environment, whether it be temporary or fixed or otherwise.
Yeah, and I would say I would agree. We're going to bring case studies from all over the world. I'm going to be talking about a hospital I'm helping to design in Pakistan. Obviously, you know, we're all aware of what's happening in the tragic situation in Europe right now around Ukraine. These millions of refugees adding on to the 5 million refugees from the Syrian conflict are influencing and shaping designers. So of course, they're relevant to the conversation. The bottom line is the principles for designing itinerant or fixed facilities are the same principles. The quadruple aim lives hard and strong in both settings. If we've learned anything from COVID is that we need less buildings and we need more non-building based healthcare. So more remote patient monitoring. I'm part of a group now doing remote patient monitoring to Ukrainian refugees in the forest right now. Okay, so this is happening this week. So this is not some utopian thing. The principles were learned during COVID, and now they're being applied to itinerant healthcare in a forest in Ukraine based on things that were designed 2 years ago because of the COVID pandemic that forced us to move from building-based healthcare to home-based healthcare to other types. So it's a really good and important point about how in the past, we would artificially say, you know, fixed buildings and non-fixed buildings or tertiary and primary. Our principles that Sean and I believe is that these principles apply to all levels of care. And COVID has invited us and pushed us to think very differently. And so we're moving from this idea that healthcare is only at the building on the top of the mountain or hilltop, but really healthcare is diffused. It's in the community. It needs to be in the community. Home-based care, chronic home-based care. A lot of forces for 40 years now are lining up thanks to COVID, if you will. That means financial parity. That means governments supporting non-hospital-based care. So financially and organizationally, it's much, much easier to apply these principles to all itinerant healthcare systems, including home-based, work-based, or refugee camp-based. In my mind, they all fall, unless the principles are aligned, then you get this massive dissonance between the money being sunk in these big buildings versus where most of healthcare is. And 98% of healthcare is not in hospitals, it's outside of hospitals. So we need to align the creative designs for those types of settings.
Yeah, I grew up in Florida, so I have experienced emergency medical management all my life via hurricanes. So I've been involved in the design of some of those environments and some of those systems. And so we'll use those as case studies as well.
Thank you very much. Yeah, that was very illustrative.
And maybe I can add to that we have across the program also other experts being involved, and those are architects and designers that specifically maybe address healthcare in the global south. Yeah, and so we are seeing that as, of course, as not an emerging problem, but as a permanent issue that has to be dealt with. And yeah, as Paul said, I mean, we didn't specifically allude at the moment to safety issues of different sorts as we see right now in Europe, but definitely, I mean, this whole migration issues that will come upon us in the next coming years will certainly accelerate certain changes on these larger models that we are dealing with. How healthcare is being produced, how healthcare is being dealt with in different countries, and how can it adapt to those enormous changes that we are facing right now.
Exactly. So, like my research is in Jordan, refugee camps in Jordan, and we have like between the West Bank and Jordan, we have 1.5 million people living in refugee camps for the last 70 years, 50 to 70 years in between. And that's why like that question is very, very prominent, which is why I think this is a very important subject to deal with.
Yeah. So we are a bit over time, so I would like to maybe conclude this session today and thank everybody who participated, and in particular, of course, our experts, Paul and Jean, for leading this kind of discussion into their depths of experience in many years of practice. And looking forward to welcoming some of those participants today as collaborators, as students in what we are kind of embarking on as a new collaboration among disciplines and here at NYIT. And Alessandro, you want to have some other word on?
No, I think that this was great, absolutely, and really very a point of reflection, which is very important. Thank you for your contribution, Paul and Sean, and thank you also for our public for the engagement. And really, I would like to start next time again from the video you shared, because it's still moving in a way, Paul. And I think there is a lot to say from there. We don't have much time, but I would like to have the chance to discuss more about this. I think was a key point of, where we have to discuss about sensitivity.
I'm glad you said that. And Sean and I's goal is to open every class, if possible, with real patient stories, either written, narrative, video, audio. The idea is never to forget the patient's voice and to make sure that voice is throughout all stages of design, something that is really a novel way. I mean, we do have some patient and family involvement in design. I'd like to see it throughout all stages. And that, I think, will help to elevate the importance of the centeredness of client-customer design in all phases: primary, secondary, tertiary care, and of course, as it relates to home-based care, community-based care, or hospital or clinic-based care.
Thank you very much. Thank you very much, Paul.
Okay, thank you very much, everybody. And yeah, welcoming you to our next session, soon to be announced. Thank you, everybody.
Ciao.
Bye. Ciao.
Bye, Paul. Bye, Sean.